Good morning and welcome everyone. I'm Linda Tintawi, CEO of the Lustgarten Foundation, and I'm pleased to welcome you, our guests from the United States, Canada, and the United Kingdom. As the world's leading pancreatic cancer research organization, we believe, like you, that everyone needs a seat at the table for us to achieve our mission of transforming pancreatic cancer into a curable disease. Today's LustgartenLIVE symposium is very timely. Last week, the American Association of Cancer Research released its Disparities Progress Report. And while the AACR states that overall cancer incidence and mortality are declining across all groups, disparities across the cancer continuum remain a public health challenge, particularly in pancreatic cancer. The report cites the need for more funding, increased patient diversity in clinical trials, and a cancer research and care workforce that best reflects the communities they serve. We couldn't agree more. The Lustgarten Foundation is supporting work to make clinical trials more inclusive. We are also strongly advocate for expanding and diversifying the talent pool working in research, while also having a better understanding of the biological mechanisms that might drive disparate outcomes in the lab and in the clinic to improve our knowledge of the disease and to accelerate the development of new therapies for all patients. None of our work would be possible without your interest and your support. This includes today's sponsors, ViewRay Technologies, our 2022 presenting sponsor, Ibsen, our series sponsor, and today's event sponsor, Bristol Myers Squibb, who also supported the 2021 Career Development Awards and Dr. Crawford's study, which you will learn more about later on. And thank you. We encourage your questions. Please type your questions in the Q&A box at the bottom of your screen, and we will answer them at the conclusion of today's symposium. Our first speaker is Monique Phillips. Monique is the Global People and Business Group Lead of the Black Organization of Leadership and Development, or BOLD, at Bristol Myers Squibb. Monique earned her BS in biochemistry from the College of Charleston and MS in chemistry from the University of Georgia. And we're so glad that you're pinch hitting with us, Monique, from your hotel room. Thank you so much. We're so happy you could join us, and we're thrilled to hear from you.
Thank you, Linda. Thank you. It's an honor to be here with you guys. I don't know if you guys know this. I lost one of my friends last year, actually, to pancreatic cancer. So this is near and dear to my heart. And I have a cousin who's a pancreatic cancer survivor. So this means a lot to me, and I'm glad to see the work that you're doing. And on a more personal note, I remember when I decided to focus on diversity in clinical trials, one of my mentors, it actually questioned my decision because he knew that people had been talking about the need for improving diversity in clinical trials since the beginning of his career, and he was nearing retirement, and there hadn't been much change. And I wasn't deterred, right? I was very determined that I still wanted to do this because we knew the scientific case was there that drugs behave differently in people with different races. The moral case was there because we all need access. Including people who are part of the global majority just makes sense, right? When you talk about minorities in this country, they are the global majority. But the idea of improving diversity in clinical trials seemed very expensive and challenging. And I thought about focusing on, I can do some things and change patients' opinions and get them more willing to participate. I had a whole plan out, and I'm going to talk about the improvements since Tuskegee. But as I look at the data closer, I learned that it was us who overestimated the effects of Tuskegee, and we skipped over simple, more practical steps like asking, and who's doing the research. I don't know if you guys all know that the rates are very similar for minorities and Blacks in particular, and whites to saying yes, but there's a large difference in the rates of the people who are being asked to participate. And I don't know if you knew that healthcare providers that are ethnically and racially equivalent to the people who are there greatly increases the participation. And I think you do know that because I think that affects why you're choosing to do what you're doing. And then a lot of the no's are very much so due to logistical issues. So I couldn't be more excited when BMS made our commitments. We committed to improving diversity in clinical trials by having our sites in 25% more diverse locations. We committed Our foundation made their own commitment to help do work to get more diverse researchers. And I'm happy to be in my role as a leader of the Black Organization for Leadership and Development. At BMS, our ERGs are actually people and business groups, and we have full-time leads for all 8 of those roles because we're committed to diversity. We also have commitments related to workforce representation because we understand too, like you do, how important it is not only to have services for different people, but have people who are part of those services be a part of the decision making and part of the research that goes into it. So it is overly my pleasure to be here with you today, especially for my personal experience with friends and relatives who are affected by pancreatic cancer, but for those joint commitments to understanding not only the research matters, but the researcher matters. So thank you.
Thanks, Monique. We applaud you and your excellent work, and we really appreciate your letting us know about your personal relationship to pancreatic cancer. It affects all of us so personally and so deeply, and of course, the people who are here joining us today. So thank you. Last year, the Lustgarten Foundation launched the Lustgarten Career Development Awards to honor the lives and legacies of 2 iconic Americans we lost to pancreatic cancer: Supreme Court Justice Ruth Bader Ginsburg and Congressman Lewis. We created these awards to foster and grow the number of early career women and minority scientists receiving funding for pancreatic cancer research. And so it's my great pleasure to welcome back Dr. Avery Posey, the inaugural recipient of the John Lewis Award, and to introduce you to this year's recipient, Dr. Edmund Manuel. Dr. Posey is an assistant professor in the Department of Systems Pharmacology and Translational Therapeutics at Perelman School of Medicine at the University of Pennsylvania. Dr. Manuel is assistant professor in the Department of Immuno-Oncology at the Beckman Research Institute at City of Hope in Los Angeles. Dr. Posey is on his way home from Qatar today, and so before he left, he recorded a video with Dr. Andy Rakeman, our Vice President of Research. Roll tape, please.
Dr. Posey, we're so happy to have you back here rejoining us for LustgartenLIVE. When you joined us a year ago, you really gave us a great introduction and a great education on what the importance is of having diversity, accessibility, and inclusion within the research community, and how that, not only helps us to have a complete research community, but really how that helps us to bring us closer to our goals at the foundation of transforming pancreatic cancer into a curable disease. I was wondering if you could give a few words, kind of give us an update on how you see the field moving, if there are some changes, or what really we need to do to continue towards that goal of having a truly inclusive research community.
Sure. Thank you, Andy. Thank you for the invitation as well as the introduction. Last year, I discussed collective understandings of health equity in terms of clinical care and outcomes, accessibility to cutting-edge medicine and experimental treatments, and clinical trial participation, as well as the barriers within those areas. I also discussed diversity in the medical research workforce. And over the last 2 years, actually, I think I've observed increased interest and focus in health equity, including developing community partnerships to encourage clinical trial participation, providing travel to high volume medical centers for patients that are in geographically distinct locations. There has also been a strong focus on workforce development and diversity, with increasing number of funding opportunities for early stage and underrepresented minority researchers, as well as programs to recruit, train, and retain talented young scientists, all the way from high school students and undergraduate college students to postdoctoral fellows. I personally lead 2 research training programs for young scientists at the University of Pennsylvania, Perelman School of Medicine, and I've already observed impact from these programs. However, all of these initiatives require sustained effort, interest, and funding. And I'm hopeful that our collective motivation to decrease disparities will remain part of our new normal in this post-pandemic world. I also would like to add this, Andy, that I'm incredibly encouraged by recent results from studies of experimental treatments. So there's been 2 recently reported immunotherapy-related studies in pancreatic cancer that observed reductions in tumor burden and increased survival. One study found that a checkpoint inhibitor in combination with chemotherapy could increase survival compared to chemotherapy alone. And this study also identified ways that may help identify which patients would respond best to this new treatment regimen. And then a second study utilized genetic engineering of a patient's own immune system to target a commonly mutated program in pancreatic cancer called KRAS. And then in a report of a single patient, this personalized therapy was able to shrink the tumor metastases. And this type of personalized therapy could be applied to about 10% of pancreatic cancer patients just based on genetics. And these are two very encouraging results that provides hope that may improve immunotherapy activity in pancreatic cancer, which has traditionally been characterized as a cold tumor and unlikely to respond to immunotherapy. However, I'll add that these personalized therapies, they add a layer of complexity to treatment, and similar therapies to these are FDA approved, and they're incredibly expensive. And so it's going to be important, I think, in the next decade to not only improve our treatment modalities, but to improve the affordability and access to these types of treatments. And those discussions are still occurring today. One potential improvement that I'm excited about uses the same type of technology that was involved in the mRNA COVID vaccines, which have been incredibly safe and effective. And it was used to model treatment of patients with personalized immunotherapy. So I think that has the potential to really break down some of the barriers that we discussed last time and now.
Yeah, I believe that last study using the mRNA vaccines, that was the one coming out of Sloan Kettering with Balachandran, correct? That was supported in part through the Lustgarten Foundation and the Pancreatic Cancer Collective. And it sounds like from what you're saying, both on the research side in pancreatic cancer research and in our efforts to, as a community, to really try to be more inclusive, that there's progress happening. That's very exciting. There's a lot of promise for the future, but there's more work to be done. And really, I like your noting that it really needs a sustained commitment to driving this forward. And I think that's both true on, who we work with, who we're trying to serve, as well as the science that we're doing. And maybe that's a good transition. I know you not only are a great leader in terms of increasing inclusivity within the research community and thinking about health equity, but you also run your own research lab and think a lot about immune therapies and novel targets and how to drive things forward. So it'd be great to hear from you too, sort of what's new on the work in your lab, what's new in the project that we're supporting through the Career Development Award, and kind of what's most exciting for you for the future.
Yeah, absolutely. So I'm also very encouraged by our Lustgarten funded study. We know that pancreatic cancer, like many other cancers, exhibit changes in glycosylation. So that's a difference in how carbohydrates are presented on the surface of a cell's proteins and lipids. And we wanted to understand how these changes in glycosylation affect the growth of tumors. And we observed that tumors grow faster when a type of glycosylation called O-linked glycosylation is blocked or inhibited. And this is a mechanism that's commonly altered in pancreatic cancer and causes a change in glycosylation. So we found that this change is associated with a reshaping of the tumor microenvironment, and it changes the recruitment of suppressive immune cells, where there's an increased recruitment of these suppressive immune cells. And we know that these cells limit the efficacy of immunotherapy and immune-related activity in tumors. So we're now aiming to better characterize those recruited cells and their functions, to strategize ways to eliminate these cells or block them, as well as to understand how tumors with these changes in glycosylation are mediating all of these differences that we observe. For instance, mediating increased tumor growth, et cetera. This work is led by a very talented postdoctoral fellow in my lab, Dr. Shauna Brookins. She completed her PhD from Vanderbilt University, and she's also an underrepresented minority researcher. I'm encouraged by this study that will hopefully lead to novel strategies to target these changes in glycosylation as a way to reshape the tumor microenvironment and also have some impact in anti-tumor response. And I'm grateful for the support of the Lustgarten Foundation and its donors. Now I have the pleasure of introducing to everyone Dr. Edwin Manuel, the latest recipient of the Lustgarten Foundation AACR Career Development Award for Pancreatic Cancer in honor of John Robert Lewis. Dr. Edwin Manuel is an assistant professor in the Department of Immuno-Oncology at the Beckman Research Institute of City of Hope, a cancer research and treatment organization in California. Dr. Manuel and his team are focused on developing novel therapies to suppress nutrient uptake by cancer cells, an important process that drives progression and resistance in pancreatic tumors. His project is titled Targeting Macropinocytosis as a Novel Avenue for Pancreatic Cancer Therapy. Ed, over to you, and thank you, Andy.
Great. Thanks so much, Avery, for the introduction. First off, I'd like to thank the Lustgarten Foundation for all their support and allowing us to share our exciting work with you today. But I also like to pay tribute to John Lewis, who was just an instrumental figure in history, but also an inspiration to all of us. I can only hope to follow or try to follow in his footsteps. And so I want to start off today with my personal journey to pancreatic cancer, which I would describe as not planned, in a word, serendipitous, if you will. And so, like everyone else, my life started being born, but in my case, it was in a naval hospital in Guam. And so my dad happened to be an engineer in the U.S. Navy, and he would move from Guam to Pearl Harbor, Hawaii, to repair mechanical issues on ships, so on destroyers and carriers and whatnot. In fact, my older brother and younger sister were born in Hawaii. And it wasn't until I was 8 years old that we moved to San Diego, where my father was permanently stationed. And so that's essentially where I grew up, went to high school, but I also grew an interest in growing up near the ocean, an interest in marine biology. And so I applied to and was accepted into San Diego State University, or SDSU, and eventually focused my efforts on marine microbiology. My mentor at the time, incredible mentor, Dr. Anka Segal, she was one of very few female professors, full professors at San Diego State, who had NIH funding and also ran her own research laboratory. And so she was a strong advocate of women in science, in addition to underrepresented researchers or students in biomedical research. And it was at this point where I think learned the most about diversity and inclusion in biomedical research, and was part of a number of different minority biomedical research programs, which included MEP, which is where I served as a physics tutor for engineering undergraduates. And so during this time, I also grew an interest in HIV, so human immunodeficiency virus. And so again, I applied and was accepted into the Harvard virology program. And most of my classes and most of my research was done at the Harvard Medical School. So that picture there in the lower right is a picture of the Harvard Quad. And if you were to make a complete 180, right behind me across the street was an old brick building where I performed 6 years of graduate work with my mentor, Dr. Norman Lettvin. And so he was one of the lead researchers in HIV vaccine development using non-human primate models, so essentially monkeys, to test novel HIV vaccine approaches. So having spent 6 years with Norm, we grew a very strong bond, you can imagine. And it was during my last year in graduate school that we all found out, unfortunately, that Norm was diagnosed with pancreatic cancer. And, I really knew nothing, working in infectious disease, I knew nothing about cancer, let alone pancreatic cancer. Again, only to learn that it happens to be one of the, and still remains one of the deadliest cancers around. And I think what saddened me the most is that we were excited that the doctors had found it early. They said that they were lucky to find the pancreatic cancer early, or diagnose it early, only to find out that even with early surgery, chemotherapy, that Norm had passed away only 3 years later, or after being diagnosed. And so I did find out during that time as a postdoc at City of Hope. And so while in Boston, his diagnosis did spark that interest, I think while I was at City of Hope and found out about the news, I really did show a more concerted effort in trying to research, trying to learn most about pancreatic cancer and maybe what I could do about it. And so I think full circle, what happened is all of the knowledge I gained as an undergraduate in microbiology and infectious disease, and as well as in therapeutic development at City of Hope, I used all of that to try and develop a program to develop novel therapeutics for pancreatic cancer. And so that is where I am currently. I'm, as Avery mentioned, an assistant professor in immuno-oncology, mostly developing experimental therapeutics. And so what do I mean by applying what I've learned to develop novel therapies for pancreatic cancer? So next slide. Right, so my background was in bacteriology, and in fact, as a researcher in HIV vaccine development, we used bacteria as a vaccine vector to elicit incredibly strong immune responses to different HIV antigens. And so my current work is using modified bacteria as cancer therapy, and we call bacteria bugs. And so we normally or generally use the term bugs as drugs, so bacteria to treat the cancer. And if I could draw your attention now to this dapper gentleman here in the lower left, his name is Dr. William B. Coley. He was a surgeon back in the 1890s. And, when we think of immunotherapy, we think of CAR T cells now and immune checkpoint blockade antibodies. But what many people don't know is that bacteria was the original immunotherapy. And this particular doctor here had observed in cancer patients with visible tumors, either on their neck or on their face, that were sick because of a bacterial infection. He observed that their tumors would shrink. And so he discovered that was because the bacteria would invade and colonize these tumors and recruit an immune response that caused tumor cell death. Of course, that program back then was canceled because it was very dangerous. There was really not the knowledge or technology to modify these bacteria in order to make them safe in patients. And so, Dr. Coley was considered the father of immunotherapy. Now let's fast forward to 2022, where we do have the technology to manipulate these bacteria and make them safe while retaining their quote unquote anti-cancer characteristics. And so, as I mentioned, bacteria themselves have a high affinity or are able to colonize solid tumors. And so this is in contrast to chemotherapy. When we think about chemotherapy, they're delivered systemically, intravenously, orally, and they act systemically. So in addition to killing tumor cells, they also have detrimental effects on healthy tissue as well. Now imagine a bacteria, and the bacteria of choice, or the strain that we use, because it has the highest affinity for solid tumors, are attenuated strains of salmonella. And so imagine that you inject the salmonella intravenously or orally. Over time, you can find them only in the solid tumor. And we've shown this numerous times, especially in pancreatic cancer. And so that's one of the favorable characteristics of salmonella. Secondly, they're self-regenerating. So what does that mean? It means that you can take the bacteria or the therapy, put it in simple growth medium, and it can replicate itself. So it makes it relatively cheap to manufacture. And this is something that the NCI has been pushing, the use of bacteria, because in doing so, we can develop something, again, easy to manufacture, that could be distributed to developing or underdeveloped countries relatively cheaply. And so, previous studies had shown that while these vectors can colonize solid tumors, their therapeutic effects could be improved. And so what my laboratory has done is we've armed these bacterial vectors, the salmonella, with circular pieces of DNA called plasmids. And we have these plasmids either target proteins of interest, like immunosuppressive proteins, for example, or we have them express functional proteins like enzymes in order to degrade let's say, proteins within the tumor microenvironment. Now, numerous different strains of Salmonella have been developed, and all have been shown to be clinically safe in cancer patients, even at the highest doses. And so that leads us to work that's currently being done in my laboratory. And so what we're trying to do is really trying to affect the majority, if not all, of pancreatic cancer patients through our treatments, and not just a unique subset. And so what does that mean? We've tried to target aspects that are present in nearly all pancreatic tumors. And so one of the first things that we've developed is a Salmonella that targets the fibrotic barrier in pancreatic cancer. And so the development of this fibrous tissue around the tumor cells has been known for decades, and there have been a number of attempts to try and minimize this barrier in order to increase delivery of anti-cancer drugs. And while a few of them have made it to phase 2, phase 3 clinical trials, many have failed due to a toxicity. And so the treatments are delivered systemically, they act systemically, and so that results obviously in high toxicity. And by reducing the dose, essentially reducing toxicity, but now resulting in a loss of any effective treatment. And so again, we've developed bacteria that will actually home to and colonize and replicate within pancreatic tumors, and at the same time degrade the fibrotic barrier. And in doing so, we have shown and we've published that this results in increased delivery of chemotherapy, of checkpoint inhibitor antibodies like anti-PD-1, and the end result is a increase in anti-tumor or therapeutic efficacy. And so we are currently trying to develop these for the clinic and have recently obtained R1 funding or NIH funding for this work. Now, this leads to a second attribute of pancreatic cancer, again, present in nearly all KRAS-driven cancers, and most pancreatic cancers are KRAS-driven, more than 90% of them. And this is nutrient uptake. And so when we think about tumors, they replicate incredibly fast. They grow incredibly fast. But to keep up with that growth, they need to take up more nutrients, say, than a normal cell. And so they have hijacked processes that allow them to take up copious amounts of external nutrients in order to keep up with their growth and in order to survive. And what we've developed and what's being supported through the Lust Garden are bacteria that express functional enzymes that can block this process. And we've already shown through preliminary studies that we can, in fact, inhibit growth of pancreatic tumors with very little toxicity in preclinical models. And so what we plan to do now is we're planning to test this further in a more humanized setting, and to combine it with current standard of care metabolic inhibitors to see if they can work synergistically to prevent this nutrient uptake and also to either regress or to completely cure pancreatic or aggressive pancreatic tumors in preclinical models. And so again, I just want to thank Lust Garden for all their support. Again, hopefully within a year, I'll be able to update you on our work that's supported through the Lust Garden. And again, I'd like to thank everyone in the audience. And I'd again like to thank John Lewis for just being a pioneer in the field of being or being a role model to all of us here. So again, thank you all, and I'll talk to you again soon.
Thank you, Dr. Manuel. John Lewis said, when you see something that is not right, not fair, not just, you have to speak up. You have to say something. You have to do something. So thank you, Dr. Manuel, for doing something. Pancreatic cancer is such a high need area. And the fact that we have you with us working to transform pancreatic cancer into a curable disease in John Lewis's name is so meaningful. So thank you.
Thank you.
Now I'm pleased to welcome Monica de Avadal, Senior Vice President and Head of North America Medical Affairs at Ibsen. Ibsen has been a supporter of Lustgarten for several years, and we're thrilled that Monica is able to be with us today. Hi, Monica.
Hello, can you hear me?
Yeah, we can hear you. Go ahead.
Excellent, very well. Thank you so much, Linda, for inviting me here today. As Linda said, I am heading medical affairs in North America at Ibsen. Ibsen is a global biopharmaceutical company with a focus on transformative medicines in 3 key therapeutic areas: oncology, rare diseases, and neuroscience. And we are very proud to sponsor the LustgartenLIVE series today. So at Ibsen, we have built our strength in oncology through collaborations intended to accelerate really hard to treat cancers. We specialize in niche cancers, those with smaller patient populations where less is known and more work is needed. We focus on a select group of cancers that are characterized by their high unmet need, for example, pancreatic cancer. The nature of this work that we look at have lots of challenges inside out. And what we know for sure is that no one single person and no one single background can actually see it all. So it needs the, working together and encourage one another and challenge unique viewpoints.
Thanks, Monica. Can you just talk a little bit about what equity and diversity means to you?
Sure. So there is an author named Liz Fosslin, and she has a wonderful and relevant quote. She says, "Diversity is having a seat at the table. Inclusion is having a voice. And belonging is having that voice being heard." So for us at Ibsen, this means that we need to create a space for all and listen. And most importantly, learn from each other. We learn by creating space for all viewpoints. So by increasing diversity in our teams, we foster an inclusive culture, with diverse perspectives which are being heard, talented people that choose to work with Ibsen. That strong talent, that diversity makes us help better decisions. We can create then more innovative solutions and center our work in the areas that truly matter to those that rely on us most. So in 2021, Ibsen launched a global DNA council that brings together leaders from different geographies and functions. And together they recommend and drive the global diversity and inclusion strategy. The council members represent Ibsen business functions covering several different geographies. The council members are from different cultures and backgrounds, and so they add to the richness of the perspectives that they can provide to the diversity and inclusion work. And here in North America, we have our own D&I ambassador network that helps us integrate diversity on how we do business. And this diversion and inclusion includes our clinical trials.
Thanks, Monica. Really appreciate you and really appreciate Ibsen's efforts with diversity and inclusion to ensure that we are really searching for all of the answers, as many perspectives as possible towards cancer and towards treatments for high need cancers. So thank you, Monica, and many thanks to Ibsen.
Thank you.
Our next speaker, Dr. Howard Crawford, the scientific director at the Henry Ford Pancreatic Cancer Center in Detroit, is leading a Lustgarten-funded study called Probing Racial Disparities in Pancreatic Cancer. The study analyzes previously stored tumor samples to determine if genomic and cellular differences may account for the higher rates and poorer outcomes of pancreatic cancer in Black Americans. Dr. Crawford, your research delves deeper into our understanding of how pancreatic cancer might affect Black Americans differently from other populations. We're looking forward to learning from you how all of us might be impacted by your findings. But before you begin, I'm really pleased to announce that thanks to support from ViewRay Technologies, the Lustgarten Foundation will be establishing a pilot grant at Henry Ford for patients in your catchment area who experience barriers to accessing their treatment. We thank ViewRay for this important investment. Over to you, Dr. Crawford.
Thank you, Linda. I want to thank everybody for spending time with us today, because I do think this is a really important topic, and Linda hit the nail on the head. The idea that by studying racial disparities, what we're learning more is about the biology of this exact tumor, the tumor that we all want to conquer. So I was previously at the University of Michigan in Ann Arbor, and thanks to the generous gift from an anonymous donor to Henry Ford, they established a pancreatic cancer center and recruited me there. And one of the things that we had done in Ann Arbor was establish what's called a single cell sequencing database from the patients that were at Ann Arbor. And what we found was all kinds of interesting things about, particularly as you heard before, how the immune system interacts with the cancer and other aspects of the cancer. And we thought, well, that's really interesting. And then the opportunity came from Henry Ford, where things are very different. And we look at Ann Arbor, and virtually every one of our pancreatic cancer patients are not African American, most of them Caucasian. And at Henry Ford, 25 to 30% of the pancreatic cancer patients that are served there are African American. And so when you look at the databases, the genomic databases that exist from various hospitals and research groups across the country, across the world, it's really strange. You see hundreds of patients that have been sequenced genomically and transcriptomically and all this stuff, and you see hundreds of them, and you see like 2 or 3 of them are African American, so or from African descent. So you have to ask the question, with a 20% higher incidence in African Americans, are you really looking at pancreatic cancer by looking at those 200 people without including the people at higher risk? And I would answer that question as obviously absolutely not. We have learned so much from various populations and other cancers by focusing on higher incidence in other populations. We've discovered basic biology about colon cancer and breast cancer, et cetera, from looking at those patients in particular. And so it's overdue that we start doing this with African Americans. So my job here, and what Lustgarten has funded me to do, is to again look at retrospective samples from the past, I think it's like 10 years for Henry Ford, and find out if the genomics of this cancer in the African American community is the same as it is in the non-African American community. Not just Caucasians, but Caucasians, Asians, Hispanics, et cetera. They don't have the higher incidence that the African American community does. So it's important to know, are we looking at the same disease? Are we looking at the whole disease when we include the African American population? And beyond that, beyond the genomics, just knowing whether the mutation status of African American pancreatic cancers is the same. You heard earlier about the KRAS protein. It's a mutation in 90% of pancreatic cancers. That includes the African American community, but the type of mutation in the African American community is not the same. It's a disproportionate compared to what it is in the non-African American community, and that will potentially change how we attack and treat this cancer. And something that I've always been interested in is the basic biology of this cancer and how we can use that information to learn how to treat. And so adding more information to the basic biology is critical. So that's the one aspect of it. The other side of it is there's something called molecular subtypes of pancreatic cancer that also tell whether the tumor is more aggressive or less aggressive. We want to know if the aggressive molecular subtypes of pancreatic cancer are overrepresented in the African American community. That also will determine how potentially we would want to treat them. But beyond that, I mean, it's a relatively small study. It's going to be 75 patients, African American patients, and non-African American patients, 75 more, so 150 total. Relatively small, but what by Lustgarten actually reaching out to me and saying, hey, you've been doing this for 25 years and you're moving to Henry Ford, we see an opportunity here. And they were absolutely right. So that by funding us to do this, it has changed, I'd have to say, everything, because now I have collaborations with Gregory Beatty at University of Pennsylvania, looking at how the immune system in the African American community and inside the tumors are actually interacting with the tumor cells. I have been recruiting faculty to join me at Henry Ford, which has been incredibly easy. And one of the main things that I tell them is we have this patient population that no one's really looked at. And so everyone's very excited. So I have a whole group of scientists now that are super excited to work for me or with me at Henry Ford. And then every time I bring up collaborations to someone that's working in the pancreatic cancer field, Gregory's a perfect example. And I say, hey, we've got these 25% African-American population. They just immediately say yes. And so it's just the seed funding from Lustgarten has just, snowballed into something much bigger. And by focusing on this and really motivating me to get moving on it, and I have to say funding helps, it does, to really push forward the research. Now we've gone back into the clinical side, and just recently hasn't been published yet, but we look at, again, retrospectively at the pancreatic cancer patients that have gotten surgical resection. They've had their tumor removed by surgery, comparing African Americans and non-African American patients that have had surgery. Treatments are compatible, age compatible, sex compatible, obesity compatible. All this is controlled for. Surgical outcomes, some complications are higher in African American patients within our population, but the overall survival is exactly the same. So previous studies that have said that survival for African American patients is lower. Our study doesn't support that, but our study is also still, there's only so many patients that we can look at. And so it's also relatively small. So given the fact that I have some independent funding as well, we're going to try to fund a similar study in similar hospitals that have a similar patient population. So Emory, UAB, haven't reached out to them yet, so don't tell them, but it's coming. And Memphis in particular, these are all places that can do this kind of study relatively easily. And what this argues, just so you understand, that it's really by being treated at a multidisciplinary pancreas and pancreas cancer clinic by the same team, getting surgery, oncology, all this within the same team, it's access to healthcare that makes a huge difference in the survival. But that doesn't explain that greater incidence. And so that's what we have to focus on now. So we are trying to move what we find out from a very, very talented team of epidemiologists and statisticians at Henry Ford, looking at the environment within the Detroit area, and finding out where our patients are coming from and finding out what they are being exposed to. We've all heard of food deserts and, of course, poor diet that's associated with them. We know obesity enhances pancreatic cancer from preclinical studies and other statistical studies. So we suspect that's going to be the case, but these are all very extreme studies. We give mice that are going to get pancreatic cancer just large amounts of fat just so that they get really big. And of course, that we see that accelerates pancreatic cancer. We're actually going to take the detailed diet of what our patient population is exposed to, create that in the laboratory, and see how that specifically impacts the progression of pancreatic cancer in preclinical models. So bringing the information from our population back into the laboratory, that information, no matter what, whether you're African American or not, will be able to tell you that how does your diet influence the incidence and the progression of pancreatic cancer. So, I'm particularly proud of being able to help serve this community. In particular, it's easy to live in a bubble when you're in science. And so I think I really have to thank the Lustgarten Foundation, particularly to, I already took the job, but let's face it, you really pushed me to move forward and look at this population. And we are just doing, I think, really incredible things, recruiting incredible people. And in large part, it's because of you and the donors that give to you and support this research. With that, I think I'll just put it back.
Yeah, that's amazing, Dr. Crawford. What you said about the Lustgarten Foundation changing everything that it enabled you to establish new partnerships, new collaborations, attract new people to your lab. That's the essence of what the Lustgarten Foundation does. Is we see something, we see opportunity, and we fund something where there might not have been other funding. It's that high risk, hopefully high reward type of funding and research that the Lustgarten, that's really the hallmark of what we do. So we're very proud of the work that you're doing, and for you saying yes to us. You could have said no. So thank you for when we came to you, for you saying yes, and for seizing that opportunity, and hopefully really seeing what drives those disparate outcomes for African American patients. So we're looking forward to following your research closely, and looking forward to hearing of your new collaborations, new partnerships. We hope to see some of your young investigators maybe at the AACR pancreatic cancer meeting, and really looking forward to getting to know all of your new partners and collaborators. So thank you, Dr. Crawford, for taking your time to be with us today, and thank you for taking the chance on this funding. So thank you.
I appreciate that, but no, thank you, and you'll be hearing from us for sure.
Great, thank you. Thank you. Our final speaker is Nina Garambone. Nina is the Senior Manager of Clinical Research at Northwell Health Cancer Center. Northwell Health is our great champion in so many aspects of our mission, investing in our Walks for Research series, our education initiatives, and our new Lustgarten Equity, Accessibility, and Diversity grants. Welcome, Nina.
Thank you so much for having me today, everyone. I did have a few slides. I can share my screen if need be, although I do believe we have oh, wonderful. Thank you so much. So thank you for the wonderful intro. I am from Northwell Health. My team and I specifically do specialize in GI malignancies, and so I do work very closely with our pancreas physicians, and over at Northwell we do a lot of work with a pancreatic multidisciplinary committee, making sure that we are providing clinical trial opportunities to our patients in our communities. So we've heard a lot today about diversity in research and why it's important. And so I just want to give a quick overview of why clinical trials are important in general. I'm sure a lot of us know why, but they help to determine new treatments and interventions. Are they safe? Do they work better? Do they have fewer side effects than our existing treatments? We examine ways to detect disease earlier or preventing the issues altogether. We evaluate ways to improve quality of life, and then these can all include behavioral testing, social, environmental, and structural interventions as well. Clinical trials span a wide array of phases and a wide array of research as well. And so, why is it important that we have diverse patients on clinical trials? If you could just switch over to the next slide. I do have a interesting infographic, and some of the participants did mention the lack of diversity on our clinical trials. And so there's an article from 2019 from JAMA Oncology, and it does provide us some information about sort of the demographics on our clinical trials. As you can see, we do have a majority of white patients, about 18% Black, Asian, and Hispanic, being even smaller minorities of patients who are participating in clinical trials. And there are many factors that can influence risk and the likelihood of developing diseases. And a lot of times we don't think about some of these factors. So they include age, biological sex, pregnancy status, life experience, some of our health behaviors, so either whether they be healthy or unhealthy, environmental conditions, genetic variations, and geographic ancestry, and then sometimes the presence of comorbidities. And so diversity is so important, because as we're looking at for these clinical trials and ensuring that we are ensuring that our data is generalizable. And so it is hugely important that we're ensuring that we have representation from many different backgrounds to provide the most generalizable data for our populations. And so it's very important for FDA approvals or any approvals on really these new and up and coming drugs that our databases are including information from the vast majority. There's a very interesting trial from a few years ago in cardiovascular disease. And when you look to the demographics of the patients on those trials, they were mainly under the age of 65. However, the majority of patients that suffer from cardiovascular disease are over the age of 65. And so in looking at that data, what we're seeing is that we are not providing a very large sampling of the populations that are suffering from specific diseases. And so if you look at interesting data from, any sort of cancer, it's very rare that you would see this sort of distribution that you see here of those who are actually participating. And so ensuring that we have enough information from our populations is very important. The genetic variation and geographic ancestry is something that's very interesting as well. A lot of times we have high mix of populations within our own communities. And so they do play a factor in, health outcomes, prevalence of diseases. And so if these populations are not participating in clinical trials, we're unable to have the best information for our physicians, for our patients. This is why we are working hard at Northwell and at many of our other institutions to ensure that all of our patients have access to these trials. Some of the things that we're doing at Northwell is increasing some of our language services. So we have a big push right now to ensure that all of our patients have information, consents in their languages, or ensuring that we have translation services for patients who are interested in going on to clinical trials. We have some of our staff who spend a lot of time in our communities speaking about the importance of clinical trials and research in general. And so, they are highlighting many different groups, and we're at, many time libraries, community fairs, events. We spend a lot of time trying to get the word out there, not just for oncology clinical trials, but clinical trials in general. This distribution is specific for oncology, this pie chart that you see here. However, the distributions are very similar across the various disciplines as well. And so I think that's the end of my presentation. I know that I am between us and questions.
Thank you, Nina. Yes, it is that time for anyone who's watching who has questions. Nina, we at the Lustgarten Foundation know how committed Northwell is to inclusivity and diversity in clinical trials, because we know what happens in phase 1 trials where everything looks great and then there's no diversity, and then we know that then the trials start to fail in phase 3. So we're very grateful for your work and for Northwell's work. So if we could get Dr. Rakeman, Dr. Manuel, and Dr. Crawford back on screen. Andy, I think you had a couple of questions for our esteemed panelists, and I invite you to go ahead and take the wheel.
Yeah, no, thank you, Linda, and thank you to everybody for coming in and presenting. It truly is an exciting time with all of what's going on, but definitely more work to come and more work to be done. So maybe Dr. Crawford, I'll start with you. I think in the beginning when Monique was kicking us off, she did make the comment that the domestic minorities are often the global majorities, and that there certainly is. It's great to have expand our focus from what really felt like a almost entirely Caucasian to include African Americans. But can you comment a little bit, are there, other collections or other studies that you're aware of that can also expand the type of work that you're doing to, either other groups within the US or other groups internationally that also have different incidences and outcomes with pancreatic cancer? Or is that something we really need to look towards identifying and building those resources?
I was speaking to somebody from the UK this morning. I know it's like almost like talking to someone from the US. They have exactly the same problem. They have even fewer African or minority populations within their databases. But I don't know of any additional, at least focusing on pancreas, I don't know of any additional studies. So it's definitely needed. We need to do it. And let's put it a different way. Asian Americans and Asians in general are much lower risk for pancreatic cancer. So it's not, you don't just want to study the people that are at higher risk. You also want to look at the people that are at lower risk. You might find out a lot of really important things from those patients. So.
Yeah, no, that's good. And I think, as you pointed out too, when you made your comments of once you started down this work and started tapping into the resources that were, in the freezer and in the tissue banks at Henry Ford, everyone came out and wants to analyze that. So it's a lot about making sure that the infrastructure is there, like the desire and the questions we know are there. We need the infrastructure and the materials to be able to ask those questions. So it is something, I think, to keep on the agenda for the future, right? Of making sure that diversity is truly diverse, right? And not only in, Caucasians versus African Americans, but really across groups.
Yeah, my internet must have gone out briefly, so I caught the gist of what you're saying. And so, yeah, I think I find it fascinating. I mean, I'll just full disclosure, I grew up in Alabama. I'm very comfortable being in Detroit. It's just something I almost take for granted that, oh, it's not a big deal. But then you listen to the participation, or not the participation's high in clinical trials, but they're not being asked. And I'm sure that's the same for these databases. I mean, clinical trials we're kind of used to. We have a lot of excuses for why there's not a high representation, but there's no excuse except for accessibility to the tissues, no excuse for them not be included in the genomic databases. I just don't understand.
Yeah. And then maybe that's a good transition. So Nina, I think you pointed out a really nice list there about all the different types of diversity, both in terms of health experience, age, things as simple as age, ethnicity and genetics that play into it. As you look in terms of, who, do you ever think in terms of targets of what you really want to have for a particular trial or for trials in general? And, how does the kind of information that's been coming out around specific diseases and what really are the drivers of different outcomes, does that influence the way you set up clinical trials or the way you think about recruitment for them?
It does. So, within our department, we are working mainly with, the NCI and pharmaceutical companies. And many times, as they're designing their studies, they're thinking about sort of what age groups that they do want to include. And so they'll make sure that is included in their inclusion exclusion. So patients, we are targeting, let's say patients over the age of 70. We really want to make sure that they're able to sort of handle some of these chemotherapy regimens, right? We don't really have that many for pancreas cancer. And so we have a study specifically where we're looking at patients over the age of 70, ensuring that we're doing a really great geriatric assessment on them and ensuring that they're going to be able to handle this chemo moving forward, really looking at quality of life. And so I think that this is being embedded into trials that are being designed. I know that genomic awareness and many of our physicians and our physician researchers are really interested as well in making sure that we're targeting specific genomics. And so those are embedded into our trials as well. So I do think it's being thought about, and as we're recruiting and as we're creating strategies for recruitment, we are thinking about those specific populations. So, our physicians at Northwell do a really good job at championing these trials and making sure that we're including these specific groups. And I think at many cancer centers, they're doing the same. And so it's important research to be done. And it's amazing to sort of see the shift even over the past 8 years of how trials are being designed, handled, run, recruited for, and really seeing that shift, I think, towards genomic medicine has been interesting as well.
Yeah. And I think that that's, particularly, there's been a lot of advances in general in oncology, and we've seen better outcomes, and a lot driven by the personalization of therapies and approaches, right? And I think to some points, Monique, you were making in the beginning, that really is why it's so important to make sure that we have the people that we want to treat included in the clinical trials. And all too often we've seen this happen, where promising results in early small studies don't get replicated in larger studies, often because we're looking at different groups there. But having that depth of analysis to really understand who in those groups are responding to the therapies and being able to target them more specifically is critical. And I think we've seen some examples reported recently in pancreatic cancer at ASCO with the CD40 immune combinations run by PICE, where being able to do some post hoc seems to be highlighting groups that are more likely to respond. But I don't know, Monique, do you want to comment at all from the company perspective? What's sort of the take on this as you're looking at, markets for new drugs and how to bring them forward? How much thought goes into the target population and when and how to build that into the development plan for drugs early on?
All right, I'm very happy to say that I see more thinking about who the patient will be being more embedded earlier and earlier in the process. When you think about old drug discovery, and for my initial career, I started as a drug discovery chemist, was not as aware of some of those differences in terms of how it affected different patients. But as you see, there's a more awareness, especially since we're getting more into targeted therapies. I think that makes it even more needed. We are seeing people start thinking about that earlier. We still, sometimes struggle with getting the right amount of patients in there, but it's a process. I do see great improvements though. So I think that keeps me encouraged to know that now we're getting to the place where we're asking the question, and you can't solve for what you don't ask for. And I think at times before we were not necessarily asking about that earlier. And I think that is a great place for us to be.
Yeah, no, thanks, Monique. And I think that my training and background is in genetics. And one of the things my mentors told me right from the beginning is genetics will always give you the answer to the question that you ask. So make sure you ask the right question. And I think that becomes really critical when we're taking on such a challenging disease like pancreatic cancer, that we really are bringing in different perspectives. So Edwin, for you, I think it was really, I enjoyed your slide with your journey and your roadmap there. And it is so interesting to see people coming from different fields of biology and applying those talents to pancreatic cancer, and it really brings in different kinds of perspectives. So if you want to expand a little bit more on how you feel that having that kind of diversity of experience has helped you think differently or think creatively, and then maybe taking a step back, and you as a mentor now, how do you really help to bring new ideas, bring new talent into the field?
Right. So I learned early on as an undergraduate, being in a lot of different programs, diversity programs, that diversity is definitely better. So coming at or trying to answer a very difficult question and coming at it with different angles, you're most likely going to solve it rather than coming right at it, right? And so, yeah, I did mention that my background has mostly been in bacteriology, so working with bacteria. Even in high school as an undergraduate, even in graduate school. And in some cases would use it for genetic studies, and in some cases would use it as a therapy, especially as a vaccine for HIV, right? And in this age of immunotherapy, it's sort of come full circle. So now we can use, or we've been using viruses, attenuated viruses as therapy for cancer to elicit immune responses, and we can use bacteria as well. And some of the work that we've pioneered actually elicits totally different type of response. So not an adaptive response, but a very strong innate immune response. If you think about it, we don't really need a specific antigen in pancreatic cancer. We don't need it to be immunogenic. All we need is for the bacteria to colonize the tumor. They recruit this innate immune subset, and they kill the tumor cells sort of as a bystander effect. And so one of our particular agents that targets suppressive protein is able to cause regression in models of pancreatic cancer, lung cancer, melanoma, colorectal cancer. And it's all because of eliciting this new type of innate immune response. So again, I think that occurred because my laboratory came at it at a different angle. I mean, to hear about someone using bacteria, whenever I'm introduced and I say, here's Ed and he works with salmonella and he's trying to cure cancer with it, people generally freak out because it's associated with bad things, not good things. So again, it's sort of explaining in detail what the advantages are that these bacteria have been modified in such a way. And so in my laboratory, I don't particularly look out for, or try to develop a diversity of, let's say, researchers. I take what comes to me, and they generally have a diverse background. So I have someone whose background is in botany, and someone who was previously a store owner, a pet store owner, not necessarily looking for people who have specific training in pancreatic cancer and therapy. And what I've seen is that they do bring in different ideas. I think that wouldn't be possible from someone who maybe worked directly under me with bacteria. They'd sort of bring in the same ideas. So I do try to recruit people. I have recruited postdocs and currently have students, high school students and undergrads working in laboratories as we speak. And it's exciting to them to learn about how bacteria can be applied as therapy. And that really anything is possible, right, in this particular case. And so that's what I try to instill in my students. Keep an open mind, and things can happen like they did with me. So
anything is possible. I think that is a mantra we definitely keep tip of the tongue here at Lustgarten, because we know that there's a lot that's needed and everything needs to be possible. And maybe one last kind of point to touch on here before we look to close out. So I know both you, Ed, and Howard talked a lot about the importance on the research side of collaboration and how, having these resources made it so easy to collaborate, and Ed, bringing in lots of different kinds of backgrounds and expertise and working in different places. But maybe a question for people more from the clinical trial side, and really thinking about how do we run our trials better and how do we run our trials more inclusively. Is that something, for Monique and, both from the hospital side and the company side, is that an area where people are really open and understanding this is a challenge bigger than any one institution and we've got to be able to work together on this and compare notes and learn from each other? Or is it something where, hospitals and companies tend to retreat to their silos and go about it in their own way? So maybe Monique, you could take the first stab. Okay. I don't want to put you on the spot.
I will go first there. BMS, I can't speak for all companies, but you can think about our 5 commitments that we made. Some of that is related to even going more into diversity in clinical trials, because we understood that is important, not only where our trials are happening, but who's doing our trials. So we've made efforts to think about the investigators that we're doing, but we've also helped our sites and talked to our sites about who else is on their staff, right? Are their staff diverse? Because we know that it's not just the PI that you see or the doctor that you see, but those nurses matter. And everyone who's in that environment matters to our patients feeling comfortable. So we do pay attention to what's happening with our sites and making sure, and talking to them about diversity, making sure they're thinking about that as an important aspect. Within our own goals, we have our own recruitment, our workforce representation goals, which include some at the top of the house, so doubling our VP plus for Black employees, getting gender parity for women, and doing some other metrics for like doubling the Hispanic representation at VP plus. But then there's things that have gone throughout the pipeline, including working with the partnership with our HBCUs to make sure that we not only get people at the top of the house, but we're keeping that pipeline of talent through there. And it's important also because you get that diversity of ideas. Because if I see some things and nothing looks like me, I'll start speaking up. And there have been moments where people made ads or did other things where they were not intentionally leaving out my community. They just didn't think about it at first. And in my work, I work with, we have a disabled group as the same as my group. And there's a group for our LGBTQ BQ population. And sometimes there's some of those things that I may forget about that are very important to them. And having that person in the room enables us to make sure we're being inclusive in everything we're doing. And even just sometimes even our criteria that may change what's happening, how this ad doesn't necessarily, or even a brochure to recruit patients, if it's not being inclusive and it doesn't make them feel like they could belong or this is a trial for them, it matters a lot to have all the people in the room so they can start bringing up those things that we kind of overlook because we're sitting in our own worlds and around the people who are around us. And if we don't have all those people around us, we don't realize when we're not being inclusive. So we are being very mindful about that and focusing on not just diversity for diversity's sake, but truly making it inclusive and making sure people feel like they can belong and make sure they feel comfortable to bring up their own voice so we can make sure we're including all the patients that we are trying to serve.
We thank you on the hospital side for all of those, initiatives. It's actually a very timely question. Northwell sits on the border of Queens, New York, and it is if not the most, one of the most diverse neighborhoods in the country, with something over 350 different languages spoken. And so, having sponsors, whether that be the NCI or whether that be pharmaceutical companies who really are committed to inclusiveness for all patients is hugely important in what we are looking to do specifically at Northwell as a company, both on the patient end and on our workforce end. I think just within our research team, we maybe have about 100 staff members. I think almost 60% of our staff all speak a second language. And so it's, we are hugely passionate about ensuring that all of our patients, regardless of race, ethnicity, language, have access to trials. And we've worked very hard to ensure that, while compliantly running trials, because that's really important, and ensuring that our data is all, really good and quality, that we also are ensuring that, all materials are in patients' languages, right? It's not just consents, but it's quality of life surveys and, any medication diaries, right? Things that maybe companies don't necessarily think about, but are really important for patients to be able to do trials, right? You're seeing, patients who are, ethnic racial minorities unable to be able to do these trials because, not 3 years ago, they were probably excluded, right? A lot of our trials had inclusion exclusion that only allowed English and Spanish speakers. And so you exclude a huge part of our population. And so, we've sort of, come up in arms a little bit at Northwell and really spoken to the NCI and really spoken to these companies and said, we have these patients and these drugs are great. We want them to have the opportunity to have them. And there has really been a shift recently. The FDA has a huge commitment to this as well. And so on the site end or the hospital clinical end, yes, there's a huge movement towards all of this inclusion.
If I can put on my director's hat for just a second to address this, but first of all, thanks to both of you. But one of those things that I've been able to do, and I didn't even know I had this magic trick up my sleeve, but I see something in the clinical trial realm that I think looks really promising, and I can say, hey, why don't you need more diversity in your group? And they recognize that and say, why don't you come to Henry Ford? And to a certain extent, I know it doesn't hurt to say, and we'll fund part of it because clinical trials are really, really expensive. Between those two things, there's been a lot of enthusiasm for collaborating with us in this realm. So it works from both sides. I think everyone is starting to recognize how important it is to the point that they're putting their efforts behind it. So I want to thank you both for that.
Yeah, no, thanks, Howard. And I'll just make one last comment before giving it over to Linda to close out. I think that what you just said is much like the challenge that we faced in solving the biology of pancreas cancer and coming up with solutions. The solving the how to be inclusive of people is going to take more than one approach, and it's going to take that kind of persistent approach that we've all been talking about. And so I think it really comes back of this is the right type of group and the right type of approach to take this on, that's used to dealing with big challenges, with multifaceted challenges like this. Well, thank you all for joining us. It's been a delight and a very informative afternoon.
Thanks, Andy, and thanks to our panelists. This has been such a informative, engaging, dynamic conversation. We're so pleased. I'd like to thank again our sponsors, ViewRay Technologies, Ibsen, and Bristol Myers Squibb. I'm honored and proud to have been able to highlight the commitment the Lustgarten Foundation has made to equity, diversity, and inclusion in pancreatic cancer research, and hope all of you leave today's symposium with a better understanding of why we are so committed to this important work. Thank you for joining us today. We look forward to seeing you again in our next Lustgarten Live in November, the intersection of science and technology and its impact on research, led by Lustgarten. Thank you all, and stay safe out there.